Welcome to PharmaDocs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, hello, Dr. Robinson.
Dr. Reznick, how are you doing?
This is Robinson. Dr. Robinson.
I might as well put an I-N or a T in my name. Sometimes I thought about doing that as well.
Yeah.
How we been, man? You good?
Good. Everything's good.
Awesome. More drugs are getting approved.
Yeah, I know. 10 this month, or actually last month in June, 10 new drugs. And just because we all have families and plans, we're only going to cover 6. And I picked 6 that I thought were kind of the most germane, the most relevant to what we do in dentistry.
Right.
And some that would be of personal interest to us too. So let me bring these slides in. Oh, there we go. There's both of us. Okay. Yes. And so today is July 14th, 2023. I can't believe it's middle of summer already.
Yeah, I think if we follow the tax season, I think we finally got to where we're working for ourselves now, correct?
Yeah, I think so. And especially, for summer, I've been seeing so many wisdom tooth consults. It's crazy.
Yeah, so it's just nonstop for all of that.
Yeah, which I don't mind. Because it knows we have a lot of. It means the end of July and all of August are going to be very busy.
That's exactly right.
Yeah. So
we can
pay some bills.
I'll tell you something else is busy. The big pharma business. Okay, I mean there are always new drugs coming out. Jay, it's just the month before we had 17 new drugs. Couldn't even talk about all of them.
Yeah, 17.
And now this month we got 10. And then I continue to read reports just like you do. This new drug coming out promising for this. This new drug coming out promised for that. It's just exciting because we're having so many first-in-class new drugs coming out.
Yeah. I mean, things we never would have dreamed of when we were in school or residency.
And wait till AI gets involved with this. Okay.
Yeah.
Scary.
And like all the personalized medicine too.
That's correct.
Yeah. From people's own cells. So I want to start off by thanking our sponsors, iCore. Connect iCore RX, which is a great company that does electronic prescribing. I think most people, most dentists, most states in the U.S. Are pretty close to or are now mandating electronic prescribing for not just controlled substances, but for every prescription. It's nice because, our system will keep track of all the prescriptions that I've given to the patient, as well as what medications they're on. We have access to the state database, narcotics database, the PDMP, so we can see what else our patients have been taking. And I'm not getting calls from the pharmacist saying, "What does this prescription say?" So we want to welcome iCore, and then we have a new sponsor.
Yes.
The Fortune Law Firm, and they are basically established for physicians and dentists to do 3 different things. One is asset protection. They help you with your tax strategies and also with your estate planning. And it's a real good company. Hopefully, we're going to have someone from the company join us towards the end of our podcast.
Yes.
Or webcast. And we thought they'd be here already, but they're not. So,
Jay, our webinar we talked about that time that we did on patient dies in your dental office with a medical emergency gone bad. Mm-hmm. These are the kind of guys you call besides your malpractice company, Jay.
Yeah.
When you talk about asset protection, but you got to have an active medical emergency preparedness program in place as well, too.
Right. Absolutely.
You don't want to go above your policy limits. You don't want to be found grossly negligent where all of your personal stuff is on the table as well.
You want to be able to protect your personal assets.
Correct.
And your practice.
Yes.
Yeah. So it's a real great company. Hopefully they'll be joining us later.
Let's hope so.
Okay. So let's go on to our first drug.
Yes.
Roctavian.
Yes.
And this is again a new drug that's kind of first in class, and what it is a single dose gene therapy infusion for patients that have hemophilia A. And of course, with hemophilia A, they have deficiency of factor VIII, and it's a an inherited disorder. And what this does, rather than giving patients factor VIII, it actually you're infusing a working copy of the gene into liver cells. So the liver cells will up their production of factor VIII. So what's done is that this is infused into the superior, inferior, the hepatic vein, or no, let's see, wait a minute. The what do I have? Why can't I remember? Anyway, it's injected into the artery that goes to the liver, and it delivers these cells directly into the liver. They become implanted in the liver, and the portal vein, and starts manufacturing your own factor VIII. And so now it doesn't work for every patient because this is actually this is an adenovirus that's used to insert that working copy of DNA into the liver cells. So you want to make sure that, or the physicians want to make sure that this patient does not have antibodies to the particular adenovirus serotype that's used, which is AAV5. So it's essentially acting as a vector to deliver the working copy into the liver cells. So that's pretty interesting. And as you know, hemophilia A, patients have the factor VIII deficiency, and they will bleed either spontaneously or after very insignificant trauma. And hemophilia B is factor IX deficiency, and hemophilia A is what's known as classic hemophilia.
Yes,
X-linked recessive trait, and that means it's basically passed through the mother. And so,
but you know, Jay, there's a lot of contraindications with this, even though, I mean, again, this is really cool being a single dose gene therapy. Yeah. A large list of contraindications as well.
Too. Yeah, for sure. So it's basically transmitted through the mother on the X chromosome. Yes. So males who are affected don't transmit or doesn't go on to their if they have a son, but it makes their daughter a carrier because it's on the X chromosome that they basically contribute to the female. And then the females, of course, are carriers, and they will transmit it to male offspring. And it's the most common hemophilia A, and it occurs about 1 out of 5,000 males, and accounts for 80% of the hemophilia cases throughout the world. It's affecting 400,000 males worldwide. And the contraindications, there are many, including liver issues, any allergies to, for example, mannitol, which is an inactive ingredient that is in Roctavian. Yes. And also any disorder that can increase coagulability. So patients, females, are using oral contraceptives. Actually, it's not even indicated for females, but any risk factors for unwanted clots, like deep history of deep vein thrombosis, hypertension, high cholesterol, lowered immunity, those are all absolute contraindications. And if a male with hemophilia A is going to receive this drug, the Roctavian, they cannot, they've got to be protected if they have a female partner who is planning to become pregnant, because this drug will stay in their system for about 6 months after they stop it.
Yes.
Yeah. So Or actually, you know what? This it's another one that's into the inferior portal vein. This is just a regular infusion. Sorry, you should have corrected me.
Well,
I'm all confused. It's
I don't want to correct the man, because you are the man, the myth, and the legend. And
so a lot of patients have transfusion reactions to this. That's probably one of the biggest complications. That's seen in it's actually kind of one of the common side effects. So they pre-medicate the patients, starting with corticosteroid treatment ahead of time, and they of course will give them antihistamines, and they're going to monitor their liver enzymes throughout the infusion process. So the infusion itself takes about 2 to 5 hours, and it's always done in the hospital in case the patients have adverse effects. And then they usually stay overnight to make sure that it's they're not going to have adverse outcome or adverse effects to it. And the dose is calculated per body weight.
And you know, too, Jay, those people that participate in Roctavian will be asked, and more likely have to participate in a 15-year long-term study after the first injection. Okay.
Yeah. That's actually required, a 15-year registry.
So I don't even know if we'll be doing PharmaDocs in 15 years.
Yeah.
All right.
I know. Yeah. And not everybody responds the same way to this, this new drug. Some people, they do very well and have no need for any supplemental factors. Some patients can still have some bleeding, only have a partial response. And they advise patients who have been given Roctavian, no alcohol for the first year. Again, it could be transmitted to their female partner, so definitely use protection. And if she's planning to get pregnant, you got to wait at least 6 months after you're done with the infusion.
Yes.
And patients also cannot donate blood, organs, tissue, cells, anything like that. And one of the big serious side effects, of course, is hepatotoxicity and thromboembolic events, in addition to the infusion reactions that we already talked about. But common things are like abdominal pain, fatigue, headache, fever, nausea, vomiting,
run of the mill stuff.
Run of the mill kind of stuff. Yeah, exactly.
That's right.
Exactly. And they haven't really done any studies with other drugs to see how they interact. So it's, so if you have a patient who's been given Roctavian, comes into your office for treatment, of course you're gonna get bleeding times and PTT before they come in, just to see, because they'll know what their times are, their INR, when the patient comes in, because it's going to be monitored. They're also going to be having their liver enzymes monitored, ALT, AST, and so the patient will have some information to give you when they come into your office. But again, we don't know yet how any of the drugs that we're going to use in dentistry, whether it's local anesthetics or sedatives, antibiotics, corticosteroids, are going to affect this drug in the long term or even in the short term. All right. So, I forgot about that. And just to kind of review the pathway. So as you can see, factor 8 is activated to factor 8A, down kind of towards the bottom there. And this goes on to be activated to prothrombin, thrombin, and then fibrinogen to fibrin, and that the stable blood clot. So if you have a factor 8 deficiency or factor 9 deficiency, obviously that whole clotting cascade is not going to happen. Okay. So the next drug is called Lantidra. And you want to talk about that, John?
Well, Lantidra.
Or Lantidra, sorry.
That's right. Yeah. This is very interesting. Now,
this is the one that's injected.
This one's about being injected
inferior
the hepatic portal vein.
Yeah.
All right. And this is some fabulous stuff. Okay. Because we already know type 1 diabetes. That's a patient red flag to all of us. Yeah. Okay. Bottom line, when you're given the diagnosis of type 1 diabetes, we know that's a chronic disease that occurs when the immune system attacks and destroys the beta cells in the pancreas that create insulin. The beta cells create, that's right. So patients with type 1 diabetes they're going to have an increased blood glucose level.
Right. Because they're not getting it's not getting into the cells.
Correct. So they have to require regular insulin, and it may mean multiple doses throughout the day. It may mean episodes of just peaks and valley in their blood glucose level. Now, of course, now, Jay, we've got other agents out there as well, too. I mean, there's a whole plethora of diabetic medicines out of there. And we could do an 8-hour lecture just on diabetic medicines. Okay. And look, all the dentists out there, all the hygienists that are treating patients, you got to know diabetes. Okay. You got to know these patients. All right.
I mean, type 1 is the kind, that generally begins in childhood and pretty much are always insulin dependent. Whereas the type 2 or adult onset diabetes are more responsive to some of the newer drugs and some of the old guard drugs that help increase the production of insulin, because the cells are there. It's just what's happening is that the cells in the tissue are not responding to the insulin.
So, okay, so you got a patient that's not really responding well to type 1 diabetes, Jay.
Yeah.
Okay.
They've tried other medications.
They've done everything
well on insulin. They're just not doing well. They're having all kinds of hyperglycemic events, hyperglycemic coma, hypoglycemic episodes. And so
enter the picture is Lantidra. All right.
Yeah.
An allogeneic pancreatic islet cellular therapy for the treatment of a non-controlled type 1 diabetic. All right.
Exactly. And this is actually, it's interesting because
it's so cool.
This is essentially not a drug. It's a tissue transplant.
It's almost like a fancy stem cell being put into your body. Say, hey, grow more beta cells in the pancreas.
Yeah.
All right. It's targeted therapy, Jay. This is such cool stuff.
Yeah.
Okay.
Yeah. So it goes into the inferior hepatic vein, and these cells become implanted then into the liver, which produces rather than the pancreas producing the insulin, it comes from the liver.
Yes.
So this is really incredible technology, and as you would guess, this being essentially a transplant of tissue.
Yes.
Patients that come to you that have been given this treatment are going to be immunosuppressed.
Yes.
So they don't reject the transplant. So you've got to be, of course, make sure you cover these patients with antibiotics. You've got to be careful. You got to look for infection, healing delay, all kinds of things that you would expect in an immunocompromised patient, in addition to infections in other parts of the body. And so you've got to be aware of how this interacts. And this was approved just last month, and it's going to be on the market soon. And some of your patients
you're going to need to get that consult. You're going to need that consult from their physician about this, because an endocrinologist is going to be overseeing this patient.
Yeah.
Okay.
Yeah.
And make sure you talk to them, document.
Yeah. Make sure that you understand what they've received and how they responded to it and how they have to be handled in your office. So again, that's, it's going to be most likely antibiotics coverage, even though they're producing enough insulin, hopefully, from this treatment. But they're also immunosuppressed. So you've got all the things that come along with that.
Right. And to go along with what Jay just said, audience, this is long-term immunosuppression. Okay. Not just intermediate.
Forever.
It's forever.
Yeah.
That's right.
Yeah. So not only that, increase their risk of infection and healing problems, but also cancers like skin cancers and lymphomas. And I would guess oral cavity mucosal cancers too.
Yes.
Because it's, how fast that tissue turns over. One of the big side effects, or one of the big complications, is that they can actually get bleeding. The liver can bleed, And that can be a major life-threatening complication of this procedure to implant these cells. And it's done under general anesthesia, under the fluoroscope, so they can see exactly where the catheter is going. And of course, they're going to stay overnight in the hospital, at least 24 hours too, to make sure they don't have any adverse effects. The other thing is that if these patients need a transplant, let's say they need a kidney transplant, because they're already immunosuppressed, it may be very difficult for them to find a match. Exactly. And to be a good candidate. So,
but you know what, Jay, this technology is only going to get perfected. Okay.
Yeah.
I mean, it's just like when they discovered aspirin. All right. We didn't have an NSAID yet. We only had aspirin, but look what led from there.
Right. Exactly. And aspirin is still used for a lot of different things.
Absolutely.
Mostly for cardiac patients, but as a blood thinner, but it's still around. And as I've heard many times, in regard to the FDA, if aspirin had been coming to market right now, the FDA never would have approved it. But it's been because it's got so many adverse effects. But I don't think it's going to go away. So our next drug is Litfulo. Litfulo, which is, as you can see from the name, ectinib is an inhibitor, right? So this is going to be an immune modulating drug.
Correct.
Right. And it's used for patients that have alopecia areata, which is not your standard alopecia where, you get older and you lose hair. This is an autoimmune disease where patients, men, women, and even adolescents and kids will get patchy hair loss from anywhere in their body, but more usually the head or the face.
Right.
And it's caused by the immune system attacking healthy hair follicles, which basically causes the hair to just fall out.
And look at that. Here we go again, going back to your famous words, the stock mutual fund, Janus kinase.
Yeah, exactly. So it works through that pathway.
That's right.
And it basically selectively and irreversibly binds the Janus kinase 3 molecule or 3 receptor. And it also inhibits cytokine-induced STAT phosphorylation that's mediated by JAK3 dependent receptors and immune signaling on cells also. And it's thought that the way it works is by inhibiting the function of the signaling molecules and immune cells that are associated with attacking the hair follicles and causing the hair loss. And this is the first treatment for alopecia areata that has been approved for kids. Yeah. But again, these patients are going to be immune suppressed, so they've got a higher risk of infection from bacteria, funguses, viral infections, opportunistic infections, and it also increases the patient's risk of death, all-cause mortality. Usually from things like sudden cardiovascular death, myocardial infarction, and stroke, as well as developing thrombosis, both venous and arterial. And DVTs and pulmonary emboli have all been seen with JAK3 inhibitors, and also a higher rate of malignancies.
Yeah, especially, Jay, talking about the antibiotic situation. You and I have had this discussion over and over. I know out there in dentistry, there's that push not to use opioids. We get it. All right. Yeah. We understand. We know why. Then there's also that push not to use antibiotics. But in a case like this, you're thinking somebody come in with hair loss, why would I need antibiotics? Well, if you're on a drug like Litfulo or Litfulo, your immune system is suppressed.
Yeah. Any immune inhibitor. Anything that ends in INIB or any monoclonal antibody.
Or UMAB. Yeah. Okay. All right. You're not going to get yourself in trouble, Jay, with an antibiotic unless you give them an antibiotic and you didn't check the chart and they're allergic to it.
Yeah.
Hopefully we have a backup with your pharmacist. Hopefully you aren't giving it to them right then in the office.
Yeah.
But, belts and suspenders. Always check that chart, make sure they're not allergic to anything. But these patients that are immunosuppressed, you got to be on top of your game here.
Yeah. And the other thing, now that we're almost all doing e-prescribing, is that all that information is in the patient's medical record. So if you prescribe amoxicillin to someone with a penicillin allergy, you'll get a pop-up saying, "Are you sure you want to do this?" Which is really nice.
Yeah. But Jay, just like, I mean, I saw somebody the other day said they were allergic to penicillin, but they've taken amoxicillin just fine.
Yeah. Well, also, I think we've talked about this before. When a patient says, "I'm allergic to something," the next question should be, what do you mean by that? Yes. How are you allergic? And sometimes just, it
makes me nauseated.
Or my Uncle Sally or my Aunt Sally, took penicillin when she was a child, 75 years ago. And so my mother said that I shouldn't take it. That kind of thing. Or kids that had, were given amoxicillin when they were 2 or 3 and had an allergic reaction, just a rash. They're usually fine to give them a penicillin when they're adults.
Now, I'm also talking about to give antibiotics, if you do some type of invasive procedure.
Yeah.
Okay. Yeah. So I'm leaning toward oral surgical procedures in the mouth.
Okay? Exactly. So if you're going to prescribe an antibiotic, you have to have an indication. There has to be a reason why. Now, for healthy young adolescents and people in their 20s that are getting impacted wisdom teeth out, I don't put them on prophylactic antibiotics. I don't think it's necessary. I see a very low infection rate. And of course, if you put them on antibiotics every time they're exposed, it increases their risk of developing allergic reactions, of developing resistant organisms, and not being able to prescribe those drugs to them in the future if you give them without a true indication.
Okay, so going further onto this drug, there is a higher rate of malignancies, including non-melanoma skin cancers and lymphoma.
Yeah, and lung cancer.
Yes. So you got to consider the risk and the benefits when you decide to do this type of treatment. And hopefully your physician is going to discuss all that with you.
Yeah. Or with the patient. Yeah, because there are a lot of life-threatening medical problems that can occur on a patient who's taking or who's been given this therapy, like a heart attack or strokes, blood clots, and cancers, especially in patients that already have a weakened immune system, already have chronic lung disease, already have heart problems, history of MI, liver disease, also in smokers, and in patients who've been given given vaccines since they got the drug. Yeah. And also this affects metabolism, of other drugs. So again, we always talk about the cytochrome system. So things like acetaminophen that affect the cytochrome 3 or 3A, that can alter, it can bind to the receptors and basically reduce the metabolism of this medication and increase the toxicity. And also substrates like caffeine too can affect it.
Oh yeah, well. So just drinking coffee, you got to be concerned about this as well.
Yeah. All right. Well, let's move on to our next drug, which is Locodo. And Locodo is a drug.
Locodo, isn't it?
Locodo.
Yeah, it's colchicine.
Yeah, so it's not a new drug.
No, it's not a new drug. It's been around.
It's a drug that's being used for a new purpose.
Yes.
And
what a great purpose that is too.
Yeah.
Anti-inflammatory purpose.
Yeah, I mean, and most cardiac issues, especially when it comes to atherosclerotic disease, are based on inflammatory response. And so an anti-inflammatory, and colchicine is a very strong anti-inflammatory,
Yes.
in these patients who have atherosclerotic disease can be very effective to reduce their risk of heart attack, stroke, reduce the need for cardiac stenting, bypass graft, and cardiovascular death. As John said, colchicine's been around for a while, but it was used for other things, namely for treating or preventing gout. And there's one drug called Colchris for preventing and treating gout flares, and another one called Mitigary that was for treating flares.
Yes.
And just like any anti-inflammatory, there are lots of side effects from these drugs, especially effects on the GI system. Patients can have, and actually, the Colchris is also approved for patients 4 and older for familial Mediterranean fever, FMF.
Yes.
So that's interesting too. But the drug reactions can occur, and especially cause kidney disease, heart disease, ulcerative disease. It can exacerbate ulcerative colitis or Crohn's disease, cause internal bleeding, or any other gastrointestinal disorder.
So basically, Jay, if somebody has been diagnosed with coronary artery disease, besides being on a statin or maybe an aspirin, they're also going to be added possibly Locodo.
Exactly. And we put on colchicine, the anti-inflammatory, to reduce their risk of those cardiac events.
So, okay, if I have somebody come into my office, Jay, I'm going to have to say, oh, you're on Locodo. Okay, that's a patient red flag.
Yeah.
All right.
And
they're trying to prevent a heart attack or a stroke. All right. They're trying to reduce your risk.
Right. Exactly. Now, there are some drug interactions that we need to know about. And one is with erythromycin type antibiotics will inhibit the cytochrome system and cause an increase in the colchicine level in the patient's blood. And an overdose of colchicine can actually be fatal. And some of the symptoms that the patients will have, letting you know that this may be happening, is diarrhea, nausea, vomiting, intense stomach pain, muscle weakness, numbness or tingling of their extremities, slow pulse, weak or shallow breathing, and unconsciousness. And as you know, in addition, another thing that affects this that patients have to be warned about is grapefruit and grapefruit juice can have the same effect.
So there we have it. E-mycin or clarithromycin, the ketoconazole drug. I mean, these
ketoconazole that we may give for a fungal infection.
That's right. Yeah. So these could be some significant drug interactions right here.
Yeah. That can go from the patient being better because they're taking the drug to life-threatening. So,
and of course, what do you do that night when they call you, Jay, and you did prescribe one of these drugs and they start spitting out everything? Hey, Dr. Reznick, my hands are tingling. I don't feel right. I've got a lot of vomiting, or I've got diarrhea going on. He's like, well, just stop the antibiotic.
Yeah. No, I call 911 and get to the hospital.
Yeah, exactly.
Yeah.
But you won't know that unless you do something like PharmaDocs. You keep up with these drugs.
Yeah, exactly. So you guys are all in the crowd knowing about these new drugs and how they are going to affect what we do in dentistry, and how what we do in dentistry can affect these drugs and how well they work, and complications. I mean, the kind of the most common side effects from this drug are, nausea, vomiting, stomach pain, and diarrhea, but not nearly as bad as if they've got toxic levels. So they don't have the tingling.
And so, Jay, what we're talking about is, like, when you and I research all of this stuff, I mean, there's a tremendous amount of material we got to look at every single month.
Yeah.
We try to find it from being an active dentist that's out there practicing every day like you are. How would this affect our practice?
Yeah, because we know we're going to see patients on these drugs in our practices.
Absolutely. Yeah. And I mean, I see it all the time. I mean, like, hey, I remember Jay and I talked about this 2 months ago or something like that. I said, wow. I mean, patients are going to be coming to our offices about that.
Yeah. It's not an if, it's a when.
And so when we find this stuff, we want to relay it to you to make you a better clinician, a better practitioner out there, because you might get that phone call. You might be somebody that still writes E-mycin or erythromycin.
Mm-hmm.
And
especially if the patient says they're allergic to penicillin.
Yeah.
And cephalosporins.
Yeah.
And clindamycin gave them pseudomembranous colitis.
Yeah.
Like,
well, we'll just go with E-mycin. Yeah. We'll just go E-mycin. All right.
Yeah. Or Z-Pak.
Or and then which is azithromycin, but that's not, azithromycin is not listed on here.
Yeah. But you still, clarithromycin more frequently, but anything in that group, I think we got to be any of the macrolides we have to be really careful with.
Yeah,
the patients who are on this drug.
Because if you get that phone call and something sounds not right, like Jay said, either call 911 or go to the hospital there.
Yeah, just remember what I always say: if things don't seem right, there's a good chance that something's wrong.
Yes, that's right. Great.
All right, let's move on to our next drug. Which we already talked about. That is Columvi.
Columvi. The names now are something.
Yeah.
Here we go.
Reminds me of that old show, Columbo.
Columbo. That's right.
And so looking at the name, glofitamab, you all know automatically what this is. This is a human monoclonal antibody.
That's right.
And this is interesting. What it does is, it's used for treatments that have large B-cell lymphoma, which is one of the most common lymphomas, or one of the most common non-Hodgkin's lymphomas that occur from the malignant proliferation of B cells. And it's probably the most prevalent blood cancer among adults. And it affects a large number of patients. This works by basically a two-pronged approach. It's what's known as a bispecific CD20 CD3 inhibitor. And what it does is it binds both to the CD20 protein on B cells, and those are the cells that are malignant. And it also binds, it's an agonist, it binds on the CD3 protein of T cells, and those are the cells of your immune system that help you kill them, the cancer cells. So it's basically recruiting the T cells to attack the cancerous B cells right there.
But you know, Jay, okay, so Columvi, it represents something really awesome, because this has been a much needed treatment option for B-cell lymphoma patients.
Yeah.
And it had very impressive results.
Yeah.
And we're talking like a 56% overall response rate and a complete response rate of 43%.
Yeah. And so because of that, the FDA fast-tracked this to get it to market faster.
That's right.
Yeah. Accelerated pathway, which we've talked about before with when we talked about orphan drugs.
So we do got to be concerned about something. We've talked about this before in the past on other drugs that wind up with CRS, cytokine release syndrome as well too.
Yeah, as well as immunosuppressing the patient. So again, higher risk of infection. But CRS, cytokine release syndrome, is one of the common side effects of this drug. And what you see with CRS, is nausea, vomiting, fever, chills. They can have hypotension, cardiovascular problems, reduced oxygen saturation. It can be very severe. And if that's not treated right away, and these are patients that are going to need to go straight to the emergency room.
Yes.
Otherwise, they could die as a result of taking this drug. All right. And so the common side effects are things like, the usual constipation, nausea, vomiting, fever, abdominal pain, headache, that kind of thing. And it also does increase or affect lab values. So things like lymphocyte count. It can decrease the lymphocyte count, lower phosphate, potassium, sodium, calcium. And so as a result, you can have cardiac rhythm abnormalities. And of course, neutrophils. And so it affects response to infection and fibrinogen.
And so
it can affect clotting.
This is typically infused like over a 4-hour period at a treatment facility.
Yeah.
But if you have experienced, or the patient has experienced CRS, and again, I want to say CRS stands for cytokine release syndrome. Okay.
Yeah.
And, I guess we could also refer to it as a cytokine storm as well, too.
Exactly.
And they're going to keep you there for at least 8 hours, maybe even overnight, to make sure, as what Jay just said, the hypotension, the cardiovascular event, and low pulse oximetry as well, too.
Yeah. And the other thing to keep in mind is that this drug may actually suppress cytochrome, the cytochrome P enzymes. So any drugs that you give the patient, or they may be on, may have elevated levels because it's suppressing the metabolism of those drugs. So it'll be much higher concentrations.
That's right.
Than they should be in.
So they understand, Jay, they're suppressing the enzymes.
Right.
So the enzymes can't metabolize the drug like they should. So you get wound up with higher levels.
Higher levels. Exactly. Suppressing the cytokine enzymes in the liver.
That's right.
Okay. So let's move on to another drug that is probably near and dear to most of us. Well, maybe not all of us that are listening in, but certainly for me and John.
Yes.
And this is Suflave.
Doesn't that sound like a dessert? I hate to bring that up.
Yeah,
I mean,
I know.
Well, I'll take a Suflave.
So anyone who's had a colonoscopy,
yes,
you have to go through, the low residue diet and then the clear liquid diet, and then starting the night before, you have to take the colon prep.
The prep.
And it's like this big jar that's absolutely nasty tasting. And you've got to do it again in the morning before you got to wake up at like 4 a.m. if you've got an early appointment, and take it at least 4 hours before your colonoscopy. And what these drugs do is they work by osmosis to basically draw all the water into the bowel and basically flush everything out so that your bowel is as clean as possible for when you have the endoscopy. And I guess the big selling point of this drug, of the Suflave, is it actually supposedly tastes like a sports drink. It actually doesn't taste nasty. And so when this comes to market, I don't know, do you have a colonoscopy coming up soon?
It's coming up. Yes.
Okay. All right. I've got 5 years for my next one.
I'm going to ask for Suflave.
For sure. I want that Suflave.
Yeah. I want a sport drink, man.
Yeah.
Please.
Yeah, exactly. So we'll just kind of little side here regarding colorectal cancer, which, colorectal cancer screening has always begun at age 50. So you would always get your first colonoscopy at age 50.
Yep.
Unless you're like me that put it off a couple of years. But this is very common. The highest incidence of colorectal cancer is in men and women over the age of 50, about 1 in 23 men and about 1 in 26 women. And the most important screening tool that we have right now, there are going to be some blood tests, hopefully, that will test for it. Of course, occult blood in the stool is another test to suggest that maybe colonoscopy can be done. Is that it's in your colon before a colon cancer develops, you have a lesion known as a polyp, and the polyps take two forms. They can either be sessile, which means that they're flat, they look like kind of a bump, or if they can be pedunculated on a stalk, like the ones that you see. Actually, they're both represented in this illustration here. And in order to be able to see those and not be missed, you have to have a clean colon. In fact, if your colon is not clean, they usually will reschedule the colonoscopy. Then you got to go through the whole prep again, which is no fun. But the big news is that in patients who are under the age of 50 now, because the incidence was going down for those over 50 because of better screening and maybe lifestyle changes. But now we're starting to see since the 1990s for patients under the age of 50, like the 35 to 50-year-old range. It's been going up about 1% per year in that group. And the changes, the increase in younger patients is really alarming, and it can be due to things like their diet, low fiber diet, lifestyle, smoking, genetics also. But the lifestyle factors are very important. If they drink a lot of alcohol, they're not exercising, again, overweight, lots of processed foods, that can increase the chances of colorectal cancer. And these are probably the contributing factors in those under 50 now.
Yeah,
and it's scary.
Yes, it is.
Yeah, and actually, colorectal cancer is the third most common cancer in the United States. About 106, almost 107,000 new cases of colon cancer every year. All right. And of course, the symptoms of colon cancer will vary depending on the cancer size and location, but it's usually, bleeding, abdominal pain, that type of thing.
So get screened.
Yeah, get screened.
Yeah,
for sure, get screened.
Just like have your mouth checked for oral cancer.
Yeah.
Okay.
Yeah.
We much rather treat a small nothing than a big something.
Yeah.
Okay.
And so the Suflave is taken just like the standard preps about, the evening before, and then about, 5-6 hours before in the morning. The things that we have to worry about and we have to worry about if we're doing this bowel prep is it can cause all kinds of fluid changes. You can become very dehydrated, and it can also deplete you of electrolytes. So you've got to be sure that patients and you, if you're having a colonoscopy, maintain your fluid and electrolyte intake.
Yes.
Otherwise, you could end up with some cardiovascular effects, which can be very dangerous in susceptible patients. All right.
Okay.
So let's move on to our medical emergency of the month. And
gosh.
That was supposed to be come in after. So actually, this is a fairly common thing we see in our dental office, and it's patients that look like this. They're anxious when they come to see us, and some people are really anxious. And what happens when a patient is anxious and you put them in the dental chair? They can hyperventilate. Yeah. And John, what are some of the symptoms of hyperventilation that you may see in your patients?
Well, when they continue to hyperventilate right there, you can wind up with like the tingling in your fingers or numbness.
Or numbness. Yeah.
That's right.
Yeah. A patient can become dizzy or lightheaded, weak. They can even have muscle spasms.
Yeah,
because of
they're wearing
they're basically blowing off all the CO2
too. Yes.
So it's throwing off the pH as well as getting rid of all the carbon dioxide. And that's what's responsible for a lot of the symptoms. So let's talk about hyperventilation and what to do for it. So, of course, number one in all of our emergency algorithms are to remain calm. Recognize what's going on and stop your dental treatment. And it's also important. Go ahead.
No, I was just going to say, because when they sit down in the chair, that's when you're going to see it right then.
Yeah.
Because when they start having anxious or anxiety, they can either start to hyperventilate or go syncopal on you as well too.
Yeah. And you think, okay, well, if they may go syncopal, I better put them flat on their back, but that's only going to increase their anxiety. Absolutely. So you want to put the patient in what's the most comfortable position for them. And if they do become syncopal, at that point, you're going to put them back.
Yes.
If they become syncopal, you're also going to give them oxygen, which you're not going to do in someone who's hyperventilating because their oxygen is already too high. Because of the hyperventilation. It's their CO2 that's too low.
That's right.
Yeah. So
we got to try to recapture that CO2,
yeah,
and that will break this hyperventilatory response that's going on right then.
Yeah, and you use
How do we do
something that has been used for as long as I can remember, and that's the old trick of having the patient breathe into a paper bag.
Yeah, or cup your hands.
Yeah.
Or a bag valve mask, let them breathe that as well too. But that may also
paper
cause
bag
more
is
anxiety.
cheap, and it's whereas the paper bag patients can handle, and you want to breathe with them. You say you want to breathe slowly.
Great point. Yes,
slowly and deeply. So, and you say, breathe in, breathe out.
Yes,
breathe in, breathe out. You want to slow them down as well as have them recapture some of that carbon dioxide.
Because like you said, Jay, in the very beginning, they're watching you. You got to remain calm.
Yeah.
All right.
If you're not calm, they're not going to be calm.
No, never.
Yeah. And you want to obviously monitor their vital signs. And if there is anything you're concerned about, contact their physician, and then think about next time they come into your office, what are you going to do?
That's right. A little anti-anxiety agent.
Yeah. You may or oral sedation or IV sedation if you're trained.
Yeah. Yeah. But Jay, like when you're talking about monitoring their vital signs, again, you got to remain calm. Hey, Mr. Reznick, we're just going to put this little cuff on here, check on you and all that. Just go slow, take your time with them, and then have them keep breathing.
Yeah.
And one other thing, don't have staff coming in and out of the room either.
Yeah.
All right. That just raises their anxiety levels even more.
And sometimes what we'll do is we'll actually turn off the lights in the room.
Yeah. Yeah.
And sometimes we'll even, on our computer, log into Apple Music and just put some soothing music on for them.
Right. Great point. Anything to help calm them down.
Yeah.
Because if it doesn't, all right, if it does, they're breathing to the side and it gets worse and worse. Hey, look, they're blowing all the CO2 off. You've got to reverse that.
Yeah.
Call 911 now.
Yeah, exactly. And if they're not getting better, especially if they stop breathing, call 911. And if you have an AED, hook it up to them. Make sure that they didn't go into sudden cardiac arrest or
correct.
Yeah.
Yeah. So, make sure you check that pulse. That's right.
So the key with hyperventilation is to recognize it quickly and to deal with it quickly but calmly.
Yep.
And
great point.
Help soothe the patient. So that's our emergency for this month. And we just want to remind you about some of the online offerings we have with dentallearning.net. We have our pharmacology series, 15 modules that goes over every class of drug that your patients may and will walk in the door taking.
Yeah, if you can't find a lecture, there it is right there.
Yeah,
we're going to keep you updated.
Yeah, and then we have our DOMES program.
There he is,
which is our dental office medical emergency simulation.
Yes,
five different modules.
Great modules. Great.
Yeah, each with different emergency situations and how to deal with them. And it's only $99. And the nice thing is you can go back and watch it as frequently as you can within a certain period.
Because there's so much stuff on it.
Yeah.
It takes a lot to be prepared.
I mean, you're going to go through it. You're going to kind of digest it and then want to go back and see it again, go through it again, which you have the opportunity to do that. Another course that I've done is responsible opioid prescribing for dentistry.
Yes.
And the course that's on Dental Learning is a 3-hour course that basically includes all of the topics that are required by every state in the country, in the U.S. They're all a little bit different. Some states, I think about 2/3 of the states now have a requirement for opioid CE. Some states like California require that the person, the provider of the CE is registered as a registered provider for the opioid course with the California Dental Board. So for California, I have a specific California course. I just gave a course in Cleveland a couple weeks ago, and a few weeks before that in New Jersey. So you can take the 3-hour course to qualify for those. And of course, it's 3 hours towards your mate requirement.
Yes.
Which we all have to make sure that we're compliant with, especially if we are renewing our DEA permit in the next few months. And then John and I did a webinar not too long ago. And we'll talk about that, because this was kind of your baby.
Well, yeah, because you know, what are you going to do? What's going to happen to you next if you don't get prepared? So,
yeah,
you know, Jay and I did this webinar. Patient dies, medical emergency gone bad in your dental office, and trust me, it's happened to quite a lot of dentists over the years. All right, they had a medical emergency. They weren't prepared. They had a bad result, and unfortunately, Jay, they lost everything.
Yeah. Yeah, not just the patient, but everything they've been working, everything they went to school for so long and worked so hard for.
Well,
and
they didn't take that medical emergency training seriously.
So they weren't prepared. They thought, oh, that'll never happen to me.
No. Yeah. And they relied on dental school memory for treating a medical emergency.
Yeah. Yeah. How much do you remember from dental school? I remember the parties we had and the ski trips, but all the specifics of what we learned in dental school, you know, it's hard to recall those things.
That's right.
And so this is, again, a very important course. So we just want to thank you for your attention on this month's episode of PharmaDocs. We're going to be back again August 11th, talking about new drugs that have been approved in the month of July. And of course, a new medical emergency. And you can, again, check out all of our courses on dentallearning.net. Were you going to say something, John?
I was going to say, and we may have some new announcements to make as well, too, Jay. I know we've got an advanced emergency course coming up in October.
We'll talk about that.
We'll talk about that as well, too. We're very excited about that, because there's never been a course out there with skill stations.
Exactly.
And Jay and I are bringing that to you, but only 80 people can participate. That's it.
Yep. We only have so many because it's a hands-on course.
Yes.
Okay. All right, John. I will see you on August 11th. And I'll probably see you before then. But
absolutely, Jay.
We'll see you with everybody else on August 11th.
Thank you, audience, so much.
Okay.